seemed to be getting warmer, but it was earlier on today than an earlier meeting. So in that spirit, a warm welcome to members of the public who've joined us both here in person and also online. A polite reminder to those who are here from the public that this is a meeting which is held in public, not a public meeting. Could I begin by asking members around the table if they would just introduce themselves? Claire, shall we start with you, please?
Hello, I'm Claire Henke. I'm the Director of Communications and Partnerships for ICB.
Oh yes, please, can you use your microphones because we don't, then people online won't benefit from your contribution.
Thank you. Ian Perry, GP and FA.
Dr. Anna Davey, I'm the GP. I'm the Mid and South Essex Primary Care Partner member.
Good afternoon, I'm Shelford. I'm non-executive member from Mid Essex ICB.
Hello everyone, I'm Beverly Flowers. I'm the Director of Neighbourhood Health.
Afternoon, Matt Sweeting, Medical Director for the ICB. Good afternoon, Giles Thorpe, Executive Director of Nursing for the ICB.
I'm Mike Thorne, Chair of the Mid and South Essex ICB and Chair of this Joint Committee. And welcome, Beverly, to your first meeting of, as we are constituted here.
Tommy Moore, and I'm Chief Executive of the ICB.
Actually, I'm Pearson as the Chief Finance Officer. Hello everyone, I'm Emily Health Director at Strategy for the ICB. Afternoon everyone, Sam Goldberg, Director of Performance and Planning for the ICB.
Good afternoon, everyone. It's Mike Hill, Director of the ICB.
Good afternoon, I'm the Chief Good afternoon, I'm Sarah Whitwell, Director for Wellbeing Public Health Supervisor. Afternoon, Lynn Stimpson, Interim Director at Mental Associates.
Thank you very much. So welcome to everybody. We've got the register of interest at its latest incarnation. That's with your papers. And then we come on to questions from the public. We've had a number of questions this time, which we will answer, but as they do not relate to the agenda of this meeting, they will be answered and responded to by the relevant colleague direct to the person who raised the question. We've had two questions which do relate to the agenda. The first is from Peter Blackman, who asks, neighbourhood health is a key priority of the NHS 10-year plan. How are alliances, integrated neighbourhood teams and primary care networks going to be developed and mobilised to achieve this goal? How are patients, service users and public being engaged in this enterprise? And Mr. Blackman also offered the assistance of the SWF Health, South London Fellows Health and Social Care Group research projects, if we could find a place for them to help us. And I think, Beverly, you're going to respond to this?
I am. So the pending publication of the National Neighbourhood Framework is a really pivotal milestone in the process for establishing neighbourhoods in line with the 10-year plan. This publication will make explicit the ask of ICBs for delivery in both 2026 and 27 and beyond. The ICB will review this guidance alongside the learning from the early implementers in West Essex and North East Essex to then formulate a local approach. Including within this will be our duty to engage with the population we serve. We're aware the Mid Essex Alliance team has engaged with the research project and look forward to seeing the output of the work which once is completed.
Thank you. Councillor Mike Eldred urged the ICB to communicate planned changes to the structure of the local NHS as early and frequently as possible to town and parish councils and offered the support of the Essex Association of Local Councils in doing this. Councillor Eldred also assured the ICB of the EALC's unwavering support, and with the degree of change in both the NHS world and indeed the local government world, we're going to need all the help we can get, that's for sure. And I think, Michael, you're going to respond to that.
I am, thank you. So first of all, we're talking before we thank
Councillor Elbridge for submission and for sharing the perspectives of Essex Town Parish Councils. We fully recognise the importance of early, clear and regular communication as the proposed changes to ICB footprints have progressed. Over recent months, we've worked to identify and praise key stakeholders, including elected representatives, to ensure that they are engaged appropriately and kept informed as plans develop. This insight is informing our approach to engagement and the sequencing of communications going forward, and we're doing that in line, in line with the national mandate for change. We are developing a comprehensive communications and engagement plan for the new organisation and welcome the offer of supports. And we also, it's important to say that we value the Essex Local Association of Councils' experience in sharing public sector communications with its members and will continue to utilise this valuable conduit to local engagement. So thank you again for constructive input and for continued support for our work.
Thank you. Thank you. That brings me now to the approval of minutes of our previous meeting. Our members' content. And if you're new, Beverly, silence means 100% endorsement. Thank you. Any matters arising from any member here, it's not on the agenda. Okay. If not, thank you very much. On the action log, you've got the action log before you there. So now I think I can move on to planning, including financial plan 2026-27. And this is going to be a team effort of Jen, Emily and Sam. I don't know who's going first.
I'm happy to pick up Mike and give the board some headlines on the implementation situation.
And may I just say, the reason why there is not a paper is this is going along at an incredible pace, even by the NHS's own standards at the moment, simply because of the transition that we are all working on. And the teams have been absolutely flat out in working against the national guidelines and time frames to make this happen. So that's why we decided it would be better to have a little look at it.
Thank you, Mike. So before Christmas, Essex ICB, as they applied for, supplied a really significant plan against an allocation of 5.3 billion, which saw us 18 million in deficit. We have been working since that draft submission to try and close that plan by working across our providers in terms of triangulation of income, reviewing some of the cost pressures that have been put through, and also looking at further efficiencies and opportunities. It's important to note that we're working with colleagues in North East and West Essex, as well as in South Essex, to bring the plans together. So there is always going to be an element of we don't know what we don't know as we're working through. So part of that has also been a learning curve as we go through this planning round. We've been working closely with providers, and Sam might actually a little bit more about that in terms of the contracts that we want to put in place for services for the Essex-wide population from 26-27 onwards, and making sure that we have assurances that there will be the ability to deliver at the level that we wish to commission, whilst also supporting us to deliver the performance standards that are set out nationally for what our providers to deliver as well. There's been a range of meetings, they are ongoing. Sam might have more again tomorrow with providers, and it's fair to say that I should say that we're working up to the wire in terms of getting those members together for the 12th of February. Essex Joint Committee will see the final version or final proposed version of that plan 10th of February in a seminar session, I believe. So we'll be able to talk to you about how far we've got, how we've closed that gap. Our ambition is absolutely to bring that gap down to break even by the time we get to the 12th of February.
Thank you, Jeb. Thank you, Chair. So with regards to activity and performance in terms of breaking down the information and really closing the gap, I think it's fair to say that we still have a gap remaining in relation to therapy treatment, alternative and evidence pathways, as well as diagnostic across our providers that come into the Essex approach. At this stage, it's also very clear to say that from the draft submission, the baseline activity that we have there presented does not include the opportunities with regards to efficiencies and demand management schemes. So as Jen's indicated, we're holding a number of performance review meetings providers to go through those plans to better understand both the finances and the activity. We have also got some sub-working groups that we're working with each of the individual providers, and those groups are cancer and RCT, diagnostics and primary care. So I should absolutely make sure that we are putting in the productivity opportunities, demand management initiatives, outpatient transformation and advice and guidance schemes. We will then be able to get to a position whereby we can see if there is any gaps, and then that will start to feed our commissioning intentions. We have to close those gaps.
Thanks. I guess just to add, we've also got a subgroup looking at our mental health commissioning and what's in the plan at the moment, and kind of agreed schemes that we have for transformation already underway in the mental health space. So there's also a lot of work going on there. In addition to the numbers side of things, we are also required to submit a strategic plan on the 12th of February. That would be called our Population Health Improvement Plan, or PHIP. I'm not quite sure if that's the acronym we're using, but the Population Health Improvement Plan will set out a high-level strategic ambition for the ICB, and then also describe how we're going to deliver over the next 1 to 5 years. As Sam said, it will include our commissioning intentions for 26-27, which will be included in our planning assumptions. So we're working very closely to line those up, but also what are our commissioning intentions over the kind of medium term. The board will remember that we had a conversation about the draft commissioning intentions that are private board discussions back in December, I would say, or November, whichever one it was. And the feedback from that is being used to inform, as is conversations with all of our major providers, and feedback that we've had from some of our council colleagues as well, which is really useful in terms of thinking about how we continue to prioritise what we want to commission over the next 1 to 5 years to best benefit the population of Essex. So the Population Health Improvement Plan will also be hopefully available on the 10th for the board to consider and submitted as in its first kind of draft form on the 12th of February. I think we recognise NHS England has set some challenging timetables for developing that strategy. So one of our ambitions can really be to test and engage the longer term components of that strategy with our partners over the coming kind of months, as we then look to kind of refresh that strategy in the coming years. But we have managed to do some engagement with partners on some of the strategic elements as well as intentions, as I've described, and really appreciated all of the input that we've had from public partners, clinicians, and colleagues across the health and wider care system. So,
questions or comments about that plan preparation? If you want to come in.
Yeah, how does that challenge fit in with the £19? Is that reduced or is that gone higher in terms of the bulk cost?
So Essex ICB has had, as is every other ICB in the country, had a reduction made from their allocation. So the funding that we've been allocating has been adjusted. I think they're terming it a commissioning adjustment as such. And that then has taken the required saving out of the ICB. What is that? That has then left us with a residual amount, which is the £19 a head, which is the consultation that we're going through at the moment to be able to deliver a structure that can live within that from 26-27.
And can I ask Sam, in terms of the cancer, are we going to be commissioning straight away some external support from M&C, or at what point do we make that decision?
So we'll be working through the plan to see exactly what activity is required and performance associated with that. We're also working with our Cancer Alliance colleagues in regards to funding for next year, and that will be in conjunction with the providers to establish what it is that they want to put these forward for. However, how does that link in with the plan to make sure that if there are any gaps, we can close it up through that.
Thank you. Any other questions or comments? I mean, this is an awful lot of work, and not least because anyone can, is it worth, sit in the corner and write a plan, but we need a plan which everybody's prepared to get stuck in and implement and make happen. And that means we have to work with people to understand what might get in the way of various ideas that we might have and all the rest of it. And it is particularly important, this planning round, that we commit to things which we can all deliver together, because it's been made clear that the level of accountability or delivery against your promises is going to be higher than it's probably ever been before in this new regime. So we must get this right and do the best we can for our population, but I hopefully under promise and over deliver rather than the other way around. Okay, I'll move on then. Thank you very much. We come now to expiring contracts.
So the committee is in receipt of a report which is here today for agreement as we continue our preparations for what is termed the National Transfer Scheme. So as part of the National Transfer Scheme, NHS England National will be novating, supporting the innovation of contracts from their current ICB holders into their new ICB holders as we move forward. As a result of that, Essex, Mid South Essex, West Essex and North East Essex have been working together as Essex to identify all of the contracts that will be Essex ICB contract and which ones of those will need to be extended so that we can have safe transfer of those documents, those legal documents as we move forward into Essex ICB. This paper has been through Executive Committee and has been through the Finance and Performance Committee, and we have some contracts which exceed the threshold that they are allowed to agree at, which is why we have today those contracts which exceed 10 million in front of you. By and large, they are some of our significant acute contracts across the area. There's 11 in total. And they will all expire before the 30th of June, which is why they're here with me today. So the paper is set out as I've outlined, and you have an appendix which outlines the contracts that we are looking for approval to continue with into the new financial year.
Thank you. Any questions or comments, George? Okay, I mean, this is, it needs to be got right, because it's provision of services, but it's a largely technical matter at this stage. We can move from one set up to another. Happy to approve? Thank you very much. Okay, so now we go on to Chief Executive's report. Tom.
Thank you, Mike. So my report covers a number of items, and first of all, just to update around ICB transitions. So as I've set out in my report, we have now moved to kind of include computation around structures for the new ICB, and also have concluded the voluntary redundancy process that we run alongside that. We are in the final stages of working through all of the consultation feedback that we've received and reflecting on what the final structures need to look like, but we remain on track to publish those outcomes on the 7th of February, and then we'll be moving into the sort of the application and appointment process into that structure. Alongside that, we're obviously working around a whole series of other things around the setup of the new and elsewhere on the agenda. We'll be talking around some of the core governance and ways of working that we're going to need to establish for NHS Essex as it stands up on the 1st of April. I think I just wanted to put on record and for ministry doses like my own personal appreciation for all of the people who have been affected across all of the 3 ICBs as we've gone through this training process. And you know, I never cease to be impressed by their resilience and ongoing commitment to doing good things to support the people of Essex. And so a big thank you for me, and I'm sure that's echoed by other members of the board.
And Tom, to just interrupt your flow, also thank you to you and your team, because one of the ways in which we've held people together and still been able to deliver services is because you've been absolutely brilliant communicators with people out there. You'll still be accused of areas where you've been, because demand should always be high on leaders to communicate. But you know, what has been done has been very open, very transparent, and you know, anyone cannot possibly claim that those in on those crews that you and the team are open to discussion, debate, and share honestly. You know, what is going right, what is going wrong, and all the rest of it. So thank you and the team for that.
Thank you, Mike. I just provided an update around winter and obviously we had industrial action just before Christmas as well. I think the overall assessment locally and indeed across the region is that that was a very well managed period, and I think we saw reduced pressure actually on services than we have seen in previous years. Still obviously stresses at times. We did see a pickup of pressure in early January, and we are still dealing with some of that at this moment in time. I think though our escalation and existing coordination arrangements have worked well. Sam is already talking about next winter, and what I think we need to do to make sure we're well set for that. Because there's clearly going to be learning and opportunities right, indeed, both from a system response perspective, but equally also from a commissioning perspective of what we can do differently. I've also provided a bit of an update around some of the commissioning activities that we've undertaken across through the Joint Executive team, which I wanted to highlight. And so we have now seen the award of 2 significant contracts in South Essex. So these were procurements that were started much earlier on in this financial year. So we'll be seeing a new dermatology service commencing on the 1st of February 2026, and we'll see a new provider of musculoskeletal services starting on the 1st of April 2026. And so when Sam says we haven't fully reflected some of the demand management schemes, both of those two schemes will deliver significant reductions in demand on acute activity, which is great. Equally, really pleased that we were able to approve the commissioning of a dedicated site testing service to special education schools. I think that it's been significant to those children and their families, and we know that sites can be a key challenge in terms of educational attainment and so changing life chances. And alongside also the commissioning of a new GP-led breast pain clinic in South Essex Foundation Trust to help improve the pathway for diagnosis and treatment and to release capacity in that space. We also supported the additional commissioning of dental activity in North East Essex. Update around that. I think there's been a really good uptake actually of the additional UDAs from existing contractors. And that would be now moving through to a procurement for an additional 10,000 UDAs in North East Essex. But we know that there's a lot of opportunity there. And one of the key things that we're working through at the moment that sort of generally into in the planning item is we are very, very conscious to move through this transition. It's a time of really significant uncertainty to the voluntary community sector, because not only is there uncertainty from the NHS commissioners, but equally obviously there's a lot of uncertainty in some of the things then within local governments as well. So we are working our way through, and I think we're nearly there in terms of confirming contractual grant arrangements for a whole range of voluntary community organisations across those sectors. So it's time to then work with those organisations about what our future commissions and be. I think it's probably everything, Mike.
Okay, so I'll just pause you there then. I mean, so notwithstanding the unprecedented over the day, we feel setting these services with going, which is tremendous, even more tremendous for their services regarding many of these state pressures of that have also allow new demand and further down the chain, if that's the right expression. There, so I think this is very encouraging to see, and we must protect where we can those of our voluntary partners who we are so dependent, and it's good to hear that is happening. We can't square the circle. We've got to live within our budget, and so I'm afraid that's always going to be at the back of our mind. And we can't, fantasize cash. It doesn't work that way. But there is a determination. But we know we need the support of the voluntary sector to get stuff done, and we'll do the absolute best we can. And we've no intention to knowingly destabilize something where it's delivering for us. There's no question about that. I just wanted to echo that. It's really important point. Any questions or comments for Tom on aspects of the report or any other matters in his purview? No, thank you very much indeed. So the Giles will come on to you for quality.
Thank you, Mike. So I will take the report as read, but the breakdown of the report and key highlights are to note to the board both national and regional work streams, which are helping us understand in greater detail our accountability and responsibility as a strategic commissioner in relation to quality oversight, assurance and improvement and meeting NHS reform guidelines. Not least the development of the national quality strategy, which we're now expecting at the end of Q4 of this financial year, alongside national quality board guidance, which will sit in line with the strategic commissioning framework, which has already been published. Within the region, the ICB will now contribute, along with the proposed Central Eastern, proposed Norfolk and Suffolk ICBs, attendance at the Quality, Population, Health and Outcomes Committee, which will run on a 3-monthly rotation with providers in attendance as well, so that we are able to continue to review the core elements of provider oversight. And we have a formal escalation and reporting mechanism in line with our contractual responsibilities. In relation to our local position, we are, of course, completing our due diligence for quality as we move into our new geographies. We are utilising the NHS England tools to ensure that there are no gaps and that we will have appropriate information sharing post-April of this year. Given that whilst there is no quality resource being transferred into the Essex ICB team, we will ensure that we know any emerging or known risks so that we're able to understand any mitigations already in place or any escalation that we will need to make. Alongside that, as part of our planning round, we are having discussions with the provider chief nurses and medical directors to set a series of core quality local indicators, which will be mutually agreed with them, and we will continue to monitor through our contracting activity. The second part of the report is in relation to current issues, risks and regulatory activity. And of course, since the publication of this report, board members will be aware of a very tragic incident which has occurred at Brookfield Hospital. I think most importantly, it is important for us to offer our sincere condolences to the family of the individual who sadly has passed away. Both ourselves and NHS England have been informed of some initial findings of the investigation, but that process, of course, is underway, and that will maintain confidentiality and obviously linking in with the family to ensure that they are engaged in that investigation process. More importantly, to note in relation to the South Essex NHS Foundation Trust, due to the nature and ongoing concerns in relation to the quality of provision, a quality summit was held on the 12th of December, which had a number of partners and led by NHS England regional team with Care Quality Commission, General Medical Council, Nursing and Midwifery Council, and education partners involved, and up to local quality attendance. Follow-up meetings are now being set by NHS England to ensure that the actions agreed at the initial meeting will continue to be monitored and overseen, and the ICB will move into a role as being core membership of that Quality Summit update to ensure that progress is maintained and support is offered where possible. And we will work, of course, in partnership with Trust Leadership. Separately, to inform the board that the Ofsted and CQC Special Educational Needs and Disabilities, otherwise known as SEND, area inspection for Essex will be concluding tomorrow. That has been a 3-week process, and we have been working very closely with colleagues at Essex County Council and wider agencies in response to the key logs of inquiries. And of course, any recommendations which relate to the commissioning or provision of health in relation to SEND within Essex, of course, will fall to the new ICB to lead on. To note, also the Thurrock area SEND inspection has concluded, and we await the report and any key recommendations for in relation to that. Those are the key highlights, Chair.
Thank you. And as I remember, the next follow-up meeting for the Quality Summit with the hospital is tomorrow.
Yes, Chair.
Yeah. Anything you wanted to add, Sarah, around the SEND is ongoing, isn't it, really?
Yes, it is. The inspection happening this week at Essex County Council, so we'll share those findings as soon as we can.
Thank you. So questions or comments for Giles? George, were you looking to come in?
It's a more a general point, like, there seems to be a lot more demand than capacity in saying. I just wondered, in terms of the waiting times, accessibility, the product, how we prioritise that around spending plans. Because it just seems, from a society point of view, everything was growing. And getting support quick enough that then leads to further deterioration to mental health issues, for example. And I guess it's just a question of how far we go with the SEND programme to try and address that issue.
You do.
Yeah.
Well, you can both do it.
It's not funny, we'll work together. So, the issues particularly, I think the key prevalent issues in relation to the SEND agenda is around neurodevelopment disorder, so the NGT pathway, diagnostic capacity, and I think the important thing that we are doing is we have increased provision in Essex. We have ensured that we have an accreditation programme in place so that we are satisfied in relation to the quality of the provision. But I think more importantly, it is around that we are focused on a needs-led approach in relation to SEND, that we work well in partnership with education and the local authority. And I think our partnership is strong. I think it's something that has been recognised. You are right, the demand is increased, and we have to respond to that demand. And whilst there may well be weights, it's important that we are thinking of a family approach, that we're not just supporting the children or the young person, but also supporting the family, so that we're able to address those needs at a family unit level. And that's certainly the approach and the commitment that we've made from both the health and local authority perspective, but certainly as well.
No, you've covered it perfectly.
Thanks. I mean, can you name an area where demand isn't rising is the question, isn't it, really? But, you know, this is because it's families, it strikes us more clearly than perhaps many other areas. So any more questions about Charles's report? If not, thank you. And we come now to finance and performance report, which again is going to be a normal report because let's see about really, because on top of everything else, we're writing extra reports. We didn't want to go there this time.
Thanks, Mike. I think, yeah, absolutely. I'm grateful for that recognition. So we have been working really hard across Essex, as we know, to understand what the performance looks like for the whole of the county as we come together, and also what the finances look like for the whole of the county as well. So Sam and I are focused on getting those number parts of the plan sorted. We'll then have to turn our attention to what it looks like for reporting for Essex, because we will not be in a system control total. So the report that the Essex boards, ICB board sees will be very different to what the finance parts of the MSE, ICB boards and other ICB boards have seen previously. And obviously the performance metrics will present a different flavour as well. What I can say though is just give a little bit of a round robin around month 8 and how all of our organisations are performing. We are just about not quite there in terms of month 9. We have an extended month 9 timetable, given that we do a lot of work around agreement balances across into NHS authorities. So we should be able to give a position update for month 9. I would just add the MSE ICB specific control total financial report has and will be continuing to be seen by the MSE F&P committee as well. So the governance is still in place. But just to summarise from an ICB perspective, Legal Essex ICB at month 8 to continue to be on track as it does at month 9 to deliver its agreed plan with region, which is break-even position. We are showing a slight year-to-date deficit, which was all planned for and is in the appropriate trajectory to get to break-even for month 12. Hertfordshire Essex ICB and SME ICB are both as well on plan to deliver what they have agreed. So as we move forward, the component parts of Essex and West Essex in the world are moving forward. We have 3 ICBs or 3 parts of ICBs coming together, which will have largely a break-even position. We know that all providers across the Essex patch have been challenged. Some of those challenges are similar, some of them are different. You'll be aware that MSEFT continues to be in a deficit position that is stretching beyond its deficit support that has been given by the national team. I fully expect to see a month 9 shift in their forecast outturn, position that we've seen for the trust in exam 6 throughout the year. It's frustrated their attempts to get back to a break even, so we will bring the detail of that through when that is finalised.
So do you expect it to get better or worse?
Well, sorry. We really expect the deficit that we're seeing, the run rate that we're seeing, to crystallise into an adverse forecast outturn. And so they will be moving in a position of, or at the end of this financial year, which is more realistic of where we think that they will land. And the region have been very involved in the oversight and performance measures around that. PAH is delivering in line and expected to deliver in line with its deficit plans. We know they also had a deficit plan this year, and SNF will largely be as part of the system control total. SNE and that are expected to go through from in that position. SNF will be a component part of that to varying degrees. That is probably all we need to, I would say, on finance in terms of bringing that together. We will look to try and bring the proposed new Essex ICB finance and performance report through the committees in due course, so that the committee can get familiar with the sorts of information we want to and need to share with you going forward. But as I say, with the movement away from system control totals, there will be less oversight in terms of system provider financial positions, and then we decided in performance as well. But we've introduced some new information to report to help you board.
And I mean, and thinking positively about the new regime, and there will be more of the money which we are given to distribute, over which we have more sovereign control. It's going to be completely sovereign, because I guess we can all be told at some point to do something with it, whether we like it or not. But this means we should have more discretion over aspects of our spend than we have hitherto, where we've had to help system partners to get to a better place. So that's some good news. I think there's bad news in that I don't know if this regime is still there, Jen, you can tell me, but my understanding is that if in a sense you break your financial promises, the new regime means that actually you will lose more money will be taken off you if you break your budgetary promises, and part of our system is likely to be in that situation. Is that right?
Yes, I think what you're referring to, Mike, is the deficit support funding. So at this time last year, when we agreed deficit plans with our providers, the national team provided some deficit support funding in form of cash to bring them back to a break-even position. Now, the cash regime, as it stands at the moment, means that if they do not deliver to their promises, as you say, that deficit cash gets withdrawn. Though when we start to see the impact of that play through in the month-line forecast outturn changes, we can explore the impact of the run rate alongside the impact of the removal of the deficit cash support. So yes, a double whammy.
So it's going to worsen by a considerable degree the overall financial position of in the NSC patch connected with this committee of the hospital. So move on to performance. Are there any please, any other questions for Jan? It's getting to the end of the year now, so you know there's nothing in her back pocket anymore. Everybody's silent. Sam.
So similarly with one of the metrics for different, and they will be based upon the metrics that we will outline, so we'll make sure that they are representing what's moving forward. To give you a brief overview of the for UC, elected velocity, and from an NSC perspective, and all of these pathways still remain really challenged. And from an ambulance response time perspective, this does remain under pressure, significant pressure during the month of December. It's closely there with the winter pressures, the acuity, However, on a positive note, the Unscheduled Care Coordination Hub, which is our single point of access, has done some sterling work during the month of December, and our conveyance rates have reduced into the acute. So that's positive, and we'll continue to push that forward. From our performance perspective, again, another challenge. Flow has been a detrimental impact supporting that pathway. We are working with the acute providers to support them in their front door model with regards to redirection and screening, and we'll continue to support with that. We are working hand in glove with NHS as well, so that they continue to transition into the new provider landscape. From a patient flow, I indicated that that has had some detrimental impacts in terms of the front door pathway and the range of ambulances. However, the length of stay has increased slightly, and equally, they have seen some positivities with the delayed discharges. So again, those numbers are really small. We did some sterling work last year and reduced those back to COVID levels. They've gone even further below that. So that's really good in terms of the out of hospital work and the delays of community pathways, and we have significantly reducing as well. In relation to cancer, the faster diagnostic standard remains challenged. However, we've seen a small amount of improvement, but again, we'll continue to track that as we move forward. The 31-day treatment standard is delivering a fast trajectory, so this is really positive for our patients. There is no risk to that delivery continuing through Q4, and we'll manage that as we go into the new plan round to make sure that continues in that sustainability. The 62-day treatment standard is again another challenge for us. However, for the Q4 period, we've received some money from Cancer Alliance and the NHS to really focus on increasing resources and capacity at the hospital to reduce those wait times. And again, there are trajectories in place, and we're making sure that we can deliver on those. Elective care remains a concern in relation to the patient waiting in size, the 52 weeks and 65-week wait backlog. We again have some additional money this year and in Q4 for some specific sprints relating to outpatients and inpatients to reduce that backlog. It is anticipated that the over 65-week waits will be cleared by the end of the financial year. However, there will be a deficit in relation to trauma and orthopedics, which as an ICB, we are continuing to work with other providers and other ISPs to be able to reduce that further. But again, we'll continue to monitor that as we go through. So in summary, urgent emergency care, cancer and elective all remain challenged. We've got some investment for Q4 and we'll continue to push that in terms of reducing those wait times and maximising the opportunity and closing the gap as we've indicated through the planning.
Thanks. And to be clear, those statistics are for MSE. Eventually, we'll be bringing it all into one shape. Questions or comments, George?
Sound operational plan looks to me as if it was an aspiration, not built on actual things that are going to be doing throughout the year. So I guess as we go into the next financial year, how do we get assurance that what's written down can actually be achieved? And how do we scrutinise that in the way to make sure that there's not a 10, 15, 20 gap between operational plan and action? How do we actually start the year, get that number reduced?
Really important question, and one that we want to make sure that we can support with in terms of triangulation of figures that go into our ICB plan. We have been holding provider meetings with the executives, and we are checking and challenging the core activity baselines that they've got available in terms of the physical capacity, the associated workforce, and any other potential limiting factors in relation to the state requirements that will have that inability to be able to deliver, and then being really clear on what that gap is so that we can support with alternative commission limitations for that population.
Matt?
Thanks. I'm not expecting a massive answer to this one, but I read with interest an article in the British Medical Journal around cancer pathways in general. We measure key constitutional standards, but actually 30% of cancer is diagnosed of emergency pathways. And I guess it gives us the impetus as a new ICB to look at that end-to-end pathway and to understand our population as opposed to just chasing them as a standard. So it's just that reminder that so that patients are diagnosed off these acute pathways. And we've got to factor that in when we talk about cancer and totality, and that would apply to other specialty areas as well.
Anna?
I think Matt's made a really important point. I've been reflecting on this over the last few weeks after a patient of mine was referred on an urgent suspected cancer pathway, deemed not to have cancer, but clearly was not right, and subsequently was diagnosed as an inpatient. And I just felt there that what we've gone so far towards is a tick box exercise of referred down this pathway with this suspected cancer. If that's not the case, then, the patient is discharged off the cancer pathway and we're no further forward. That idea that we actually have to holistically look at the patient's symptoms and work out what the problem is, rather than whether they've actually ticked the box of the cancer pathway or not. We've gone so far from that we are now reaping the rewards, which is essentially patients bouncing around the system and often getting diagnosed later in A&E because care wasn't there in the first place, because they didn't fit the criteria of the urgent suspected cancer pathway that they were initially referred on. I've got many cases like this over the last 10 years. So, we've driven so hard to try and meet these standards, and actually what's happened is that patients are falling between these pathways. So I think we do need to look again at how we diagnose cancer from the start, because I don't think this current way of doing this is working.
So just so that I understand, I'm sent off because I believe it's the knee bone, and it's actually the toe bone, if you see what I mean.
I mean, it's not normally quite that simple. It's more like
Sure it is.
Suspicious ultrasound scan which suggests renal cell carcinoma. It's not renal cell carcinoma. We don't really know what it is, but it's not renal cells, so off you go. And then actually it turns out to be lung with metastases, and actually that's diagnosed several weeks later in a hospital inpatient stay. So it's just trying to work out how we do things differently, which keeps the patient-centered care at the heart of what we're doing, and doesn't sort of sacrifice that for the target.
I understand, and I have got you drift. Thank you for verifying that. Ian.
Thank you. I guess I just want to add on to that and totally agree that there's lots of different ways to tackle this. And I think in our mindset, everything has to go through the GP and through this sausage machine, be put in the right channel and get the right outcome. And sadly, that's, well, not always the case. So I do think sometimes I've had a patient who went to A&E 3 times, didn't feel right, but then they came to us and in the end got diagnosed because they went through the pathway. But I really can't blame A&E because they've done a lot of tests while he was there, but not enough to keep him in, but he didn't sort of, fit all the criteria to be admitted. The point is that I think as much as we like to control things, it's not always straightforward, is it? Life is complicated, and these things are not always going to go through the pathways we set. And I just think that's acknowledging that, because any deviation from that's seen as a failure, and I think that's really sad when it's just, in the end we all got round and we managed to diagnose them somehow. So yeah, just recognising that.
Thank you. Any other questions or comments? Okay, so I think we're done on finance and performance, and we'll move on to the neighbourhood report. Welcome, Beverly.
Thank you. I'll take the report as read. And I recognise it covers a lot of work and has a lot of narrative in it. And we will need to do something for the new board that's really clear about what does primary care look like overall, what are the challenges and what does the variation look like. But I'm still getting my head around some of that myself, but I think there's a really big piece of work to do to make sure that the board gets itself with the level of understanding of what does primary care and what's our approach to neighbours look like across the board of Essex. But I will pick a couple of bits up from the report, a couple of the themes. So one is around primary care access, where we recognise that going forward, it remains a key responsibility of the ICB and links into the 10-year plan. But against the £19 a head, we're beginning to look at how we can get this delivered in a different way. How can we work differently with primary care and others, around the sharing of good practice and perhaps embed some of this learning in the approach differently. So rather than do it ourselves, how you facilitate some others to do it and perhaps look at contracting some of this work. There'll be some information coming back to the board on that hopefully in the near future. Then we picked up in the report some stuff around COVID vaccination, and I know it's been discussed with Essex previously, and I'm not sure if this board or another group around the fact that currently NHS England gives us additional funding around supporting the COVID vaccination programme, and they're now confirmed that going forward into next year we will receive an allocation of £250,000 outside of the £19 to pick up that responsibility. I think it's really important that when money is tight and we're kind of honing down on what do we do, that we understand and we make good use of some of that money that comes into a different route. So we will build that into some of the work we're doing around the response to consultation. I don't have anything specific to update on the holidays apart from to say that we remain in negotiations with the landlord about going back in on site and pushing that forward, and the landlord is working with us really well now. So I think that's a really positive thing. There's quite a lot of information in this report around the work of the alliances and the pilots we already have in place around the integrated neighbourhoods. And one of the really key things for us now and over the next few months is how do we pull that together into our plan for what do our neighbourhoods look like going forward, what would our multi-neighbourhoods look like. And we're really keen, and we've got a meeting tomorrow that Tom's leading with providers across the patch to talk a little bit more around a whole range of stuff on our priorities next year, but in particular, how do we engage in that work? How do we set neighbourhoods up in the right way as part of our wider work to review community and to deliver our priorities? And how do we build on stuff that we've got coming out of North East Essex and out of West Essex, who are neighbourhood pilots? And that work is itself in very early days, so we're only just beginning to see some of that work kind of come through. We're really keen to look at how we explore the new models of funding and how we work with all partners to understand what those new neighbourhood contracts could look like and how we can use that to kind of drive change and improvement. But building on the stuff that's coming out of the pilots, and I guess that was all I was really going to say. I think it links into a massive agenda for going forward around what does that look like? How do we deliver it? The title about it scares me just a little bit more. But I think this tries to give a flavour of where we are and what next. Happy to take questions.
And I imagine you think it unreasonable as that you've been here 3 weeks and you haven't sorted it yet.
Oh, yes, I think you should give me at least another week. 4 weeks, but not something.
Well, that will be minuted, very. Anna.
So I'd just like to draw the board's attention to the figures around the KPIs, the IMTs in MSE. So, sorry, not all the figures. I think these figures are actually really quite impressive. So, percentage of emergency admissions due to falls from compare 1 October to another. So 12.4% same period last year down to 11.1%. That's impressive. Reduction in people readmitted to hospital within 30 days of discharge in November was 8.7% compared to 10.7% in the same period last year. A reduction in the number of people from care homes being admitted for a non-elective reason in November was 4.4% compared to 8.4% in the period last year. These are really impressive figures. To make that level of change in this really frail and complex cohort is really impressive. So I think these figures are very promising, and I'm hoping that if we look at the data over a whole year, we can see that sustained improvement through the IT. So, good.
Yeah, and thank you for making that point, because I agree with you. This is clear impact of the work of the Integrated Care Board's mapped.
Yeah, and that's not my fundament. Great. And actually, it's really important that the board is cited on these kind of population level changes over many years. When you dig into this around data platforms, you can see a year-on-year improvement of all of these markers. And that's a whole multifaceted approach delivered at neighbourhood health level with stewards and some of the key interventions there. So this is the kind of stuff we need to see more of a board, particularly kind of population health improvement next.
Indeed, and we obviously stewards, no doubt, in a reformulated form against budgets and things, and just keep that idea centre around our minds, etc.
Yeah, it's really, I see, and I guess now we've going forward is, can we build in and build on the things that we've got that we know are working well, because it'll be more effective in the long run. And especially when we're talking about the prevention agenda, there's no point duplicating things if we've got things that we can scale up or do differently.
And I heard you say, Beverly, that you're going to work on the sort of how this report will look, and it's going to be, data driven in all aspects, which would be great. Be nice to hear some more detail about these national neighbourhood pilots that are going on. I mean, there's Lynn there, and I had the benefit of listening to her talk in London around this topic. And so, it would be nice that this committee could be fully informed by thinking and also some of the debates behind it, because I know in some of the pilots they're approaching it as I believe these are, which is around those people who come to healthcare more often than others, but others have addressed it in completely different ways. For example, majoring on triage and how that might benefit and reduce demand and allow therefore extra capacity to bring people out of the hospital. So it'd be wonderful to see that embodied in our papers. I shouldn't have to go to London to listen to this. Is there anything you want to say about that work?
Not at this stage, but there is a lot of difference and variance in the pilot schemes, and I think that richness of what we can bring to the Essex ICB and the learning across the patch will be really key. They are different, but our populations are different, and what are the elements that we can standardise and scale, and then what the bits that need to be different because of our population. So I'm very happy to really start next month.
So further questions or comments about and we had in Tom's report good news around dentistry and things like this, which continues to amaze me, the progress we've been able to make, because if I'd gone to see somebody with a crystal ball, I would not have expected that to be an answer, which is that we would make some very, very good progress in this area. And let's be clear, still not where any of us would like it to see, but I don't think any of us could have imagined that we would have made that progress in the time that we have. Okay, thank you very much indeed for the report. We move on now to the exciting topic of general governance.
So I can say a few words, and I don't know if Michael, you might to jump in as well. So you've got the board assurance framework in front of you, and there's sort of, I guess, two parts. There's an updated in the paper around some of the work that's going on around the construction of board assurance framework for the new ITD, and so there's been a lot of work across teams around doing compare and contrast between the food maps across in South Essex, Hertfordshire, and West Essex, and something of East Essex, both in terms of composition, but equally also in terms of kind of where there's consistency and where there's not consistency. And I think broadly, kind of the assessment is that the strategic risks are very similar across the three ICBs and that operates. But you have got some further analysis within the pack. In terms of the board assurance framework more broadly, you can see there's been a number of changes to the board, and so the primary care risk has been reduced from Rep to Amber, and the execs then considered a number of other areas as well. So I think this is here for noting and for the question of Michael's and we want to say that we need to.
I think that covers it. I would just say for the board's assurance that I think we're obviously coming on to a couple of items talking about future governance and actually how we properly embed risk within that governance and make sure we're dynamic is a key part of our conversation.
The pleasing thing was that there is such overlap within thinking, and actually where there isn't, it may well be it's just a different expression of the same things really. And it is important because finance is a big component of this as is forward. Any questions or comments on the No, thank you very much. So we move then on to proposed Essex ICB governance. So now this is the future.
Thank you. We're starting with the proposed Essex ICB constitution. So just so members are aware, if they're not already, we're required to have a constitution we expect under the Health and Care Act. The Act also sets out that we have to base that constitution on the model constitution that is published by NHS England. So therefore there is not a great deal of variance across ICBs at present and in the future in terms of their constitution, what they have in it. The team has been doing some work to consider the constitution of MSC, ICB, and also Hertfordshire and West Essex, and subsequently North East Essex is implemented where parts will be moving into Essex ICB and have developed the constitution that's been shared with the committee today, and have also ensured that it's compliant with NHS England guidance, legislation, etc. As you would expect, the report contains the kind of key areas you'd expect to see. Sorry, the constitution contains the kind of key areas you'd expect to see. I think I would just flag that some of those areas remain under review, particularly around future membership, as we go through as an organisation a process of identifying a permanent chair for the Essex ICB. We're leaving that open to discussion once we know kind of the future in that regard. And also NHS England themselves have said that they may well be making some amendments to their model constitution, which we would likely need to adopt, or most certainly need to adopt. So the document that's been shared with me today is a work in progress, but we are required to share that work in progress with NHS England by the 31st of January. So we brought it here for views and kind of initial approval, but it will be coming back to this committee as we kind of develop the process and develop it further.
Thank you. So questions and comments. Obviously, members have had the benefit of looking at this in other fora, as is right in terms of its construction. And this is effectively a placeholder where we say this is where our thinking has got to. Is this okay so far to those upstairs who need to be aware that we are thinking about this? I think it's fair to say that between the three emergent integrated care boards in the east of England, there is still discussion and debate about what the ideal shape of an ICB board fit for purpose to deliver what the government demands of us through NHS England, and so any new thinking will also reflect what is going on there, because we all have local authority partners. In a sense, if we're going to be different, it needs to be good for good and explained reason, not because we don't want to be diverse for the sake of it. We want to work in harmony. And when it comes to actually populating what's here, then I'm sure what will be done, as has always been done, we work in harmony and in partnership with our local authority colleagues and with our provider colleagues to make sure that we get to a good place. And I'm sure it's true for the other ICBs, but what has characterised South Essex ICB is that our partner members have been incredibly constructive, supportive, and helpful, and given us lots of good ideas to help us go forward, and where necessary, pull us up where that was helpful and constructive too, and done it in a way where we can to listen to that coming up. So work in progress. Any further comments anyone wants to make at this stage? No? Great, right. Thank you very much indeed. So carrying on, Michael.
We'll carry on then to function and decision mapping, and I'm conscious of there's a lot of detail in this before the committee today, board today. So I'll just pull out a few of the kind of key bits. So as the report sets out, we clearly have to kind of consider what the right governance for the Essex ICB will be, and we have to take into account in doing that the change in role of ICBs, the change of some of the functions that have been responsible for, etc. And in order to kind of guide that design, we have followed a series of principles that are set out in the report. In particular, very keen to make sure that we, wherever possible, streamline the governance and make sure that it's avoiding duplication and as aligned as possible. So, having followed that process and having had initial conversations with a number of colleagues across the organisation and an executive team, we have developed the proposals that are before the board today, and that is largely covered in Appendix B. I think the benefits of the proposal are we are seeing a significant reduction for subcommittees, which I think will support that alignment and avoidance of duplication, and recognise the fact that many aspects of our work are all one element of the same conversation, which is how can we deliver the best for our population. We are changing the model, proposing to change the model of clinical oversight. So the president it sits within is largely provided from an advisory only clinical forum, and we're proposing instead to ensure that the clinical voice is embedded throughout the structures, and we need to really work to make sure that that is the case. We think the proposals align to the new architecture of the NHS as proposed some changes that were launched in March last year, and that they also provide clearer delegation and fewer layers of authority to streamline decision making. And finally, we're very keen, and this will come out more in the practice and the structure, to propose that we ensure that the board and its decision making and all of the component parts of the governance decision making is done based on kind of data and evidence-based approach, which will work to make sure this is the case as it often is at the moment. So those are the benefits we think of the proposal that we put forward, and that are largely covered in the Senate Appendix B and elsewhere. There are some. There will need to be further iteration with the government and further amendments of government, particularly as the wider environment in which we are operating in, continue to bed down, and there remain some questions to be answered about exactly the role of the ICB, etc. moving forward, and some of its other component parts. But that is, I think, our proposed approach at this point in time, and then aiming to continue to review it as the ICB itself has not been embedded. In terms of next steps, so should the board agree to proposal for it today, there are a number of kind of things to sit underneath it that we will then need to work on. As I mentioned in the last item, we'll also conclude before the ICB goes live the process of identifying the future chair of the Essex ICB or the permanent chair of the Essex ICB. So that may well impact as well on the we'll need to think about that as well. So we'll work forward those documents and they will come back to the board. Those are I think that's the high level summary of the proposals, but I'm happy to answer any question on the detail.
Thank you, and thank you, Michael and the team, for the work on this, because it's often thankless work. This is just so much detail that has to be there, and if it's not done well, we'll end up in a mess. So thank you very much for all of that. Can I ask our clinicians around the table, are you happy with this fundamental shift from, what was a sort of clinical group advisory to this new setup that here? I guess I'd be interested, and Matt, Giles, what are your views? You can say yes, that's fine. There's no angle. I would just like to be reassured that if we pride ourselves that we should be clinically led, that this will happen. So,
There's not significant less physical, I would say there isn't, but that isn't a change.
the most lovely way of saying, all right then, yes. Ian?
As long as it's representative of the system around, that's all, I think that's easy to say, you know what needs doing in primary care, but I know what it needs, but actually I try and canvass opinion from my district nurse colleagues and the community pediatricians, and I can't speak for the secondary care, but I'm listening. So as long as it's representative of the whole system. Yes.
Okay, thank you, Matt.
Yeah, I think it's broadly very supportive. Probably building on my colleagues' comments, two things from me is the idea of looking at total pathways and ensuring that clinicians are involved with those discussions as opposed to siloed decisions in different committees. So the role of the board and other strategic functions to bring that together. And number two is ensuring, I suppose, the interface space so that a decision that is made is considered across the system and not in a siloed way. So I think we are working through that element of governance, Michael, at the moment, aren't we? But essentially, so it's the totality of the pathway and making sure that if we're going to make a decision in X that causes a disaster in Y, we can share that quickly and rectify that before it goes live the commission pathway, and then Anna rings around and says it's an absolute disaster. So that's fun.
It's that idea that we can still act as patient advocates in some way. We do tend to think, how does this feel from the patient's perspective? I think that's what having a voice is all about. And I think if we can keep that alive in the conversation and constantly go back to, how does it actually feel to be a patient in this system, then it will strengthen the decision making and we'll make better decisions. So I think that interface space is vital, because actually, as what we do for patients becomes more and more complex, if you think about the way medicine has changed in my 25-year career, actually it's ever more difficult for people to get lost or fall between parts of the system. We've got such complicated pathways of care now. If we can bring the clinical voice to bear so that we simplify things where we can, but we strengthen the interface where we can, then we will have better outcomes at the end of the day.
Thank you. And Ian was grimacing, I think, supportively as Matt was speaking.
Yes.
So it was a positive grimace. John?
I think it would be remiss of me not to champion the other professions that exist in the system who will have a different view, who have far greater contact and length of contact and consistency of contact with our residents. And we often don't pay heed to their voice and they often don't feel heard. So I think I will champion and challenge that we have to ensure that those professional voices are heard more than they have been historically.
Yes. Sure. Okay, other questions or comments on here, on these proposals? I guess sort of, in terms of committee title, it is quite loosely and generally stated, which I think is good at this moment in time. We will need to give thought to, it says, the board will appoint this as generally as that, but I think thought will need to be given to that to meet the kind of demands we've just been talking about, but also to make sure that we have our partners in the right place and we get advice from those who are able to give us good advice in so doing. So we will need to make sure that the rubric, and I know you know this, but I think it should be said about all of this. We also must capture is on the board. It makes it very clear that people around the board table, in the existing ICB framework, and I believe in the new one too, are there coming with their expertise to contribute to the well-being of this particular integrated care board, whichever one it is. And we must, I think, enshrine that also into the work of our committees, which is that, you know, you're bringing your expertise for the benefit of the population that's here. And we've been certainly in South Essex ICB, and I'm sure in the others, we've been very lucky to have exactly that coming round the table. We've been given the professional expertise with honesty, integrity, and so on. But no one, as it were, has been peddling a particular canoe that's come to the items of the agenda and all the rest of it. And we did have rubric which captured that. And I think we should do that, because paperwork is usually about when things go wrong, not when it goes right, isn't it? I mean, he talks about votes. Well, we've never had a vote, because I personally, as chair of the meeting, unless it's ICB, would regard it as not for a vote, unless it was a matter of individual where people might feel personally regarded as having lost the plot. If we got that far, but it's there as a health thing. So if we could just capture that. Any other comments or questions from Michael on this?
I would just completely agree with that, Chair. I would just go back to my initial point, which is that the legislation tells us that we have to use the model NHS constitution. So there are several elements in that of our constitution. Actually, I would never expect us to have to use, in particular, the kind of voting mechanism, but we unfortunately won't have to.
I think it should be that. It's fine, you know. It's like those bits when you're signing a contract, I know, for your house that you can't ever bring yourself to reading it. But they are important. They're there for a reason, and it's protection of avoid feeling. Okay, so we now move on. Thank you very much, and again, thanks for the hard work. Effectiveness of the meeting. If it's an opportunity, and once we start moving into the new era, then it's going to be particularly important as we try and refocus the board away from some of the things that have taken our energies perhaps away from the more strategic things that we want to think about. It's going to be particularly important that we do think about that. But just now, in terms of moving us on towards the new ICB, people have had any comments that they want to make. I'm conscious that Emma and Claire, I'm giving you an opportunity to speak, so I've failed miserably as chairman for a start, and I apologise. But Emma, anything you would like to say?
Sorry, not in particular, just very submitted.
Thank you. Claire?
I should expect them to say, I suppose, voice of the patient and voice of the resident, I'm sure we don't put much better on that clinical voice.
Anyone else want to comment on text? Unless you're happy with the dialogue so far. Thank you. I haven't been notified of any other business, so that brings our meeting to a close. And so what I should say is it brings part one of the meeting to a close, because we have now, thank you very much, members of the public, to go on to part two, which is matters of commercial nature, where we're issuing contracts and things. So we say thank you to you. There'll be just a brief 5-minute pause.